media, organizers, ladies and gentlemen. It is a very special honor to be the host of the first ever South Asia Regional Conference on Health Informatics and mHealth being held in Dhaka. Today, I am so pleased that I am seeing you in my home country. Many others also in front of me, whom I did not see before, but know them by their names, by reading their work, or by listening from others, also make me proud. We'll also find Mr. Sojib Owaze Joy, the ICT advisor to the Honorable Prime Minister of Bangladesh, tomorrow in the closing session. I express my sincere thanks for all of them. This conference has been thoughtfully designed. We tried to bring together speakers who are experts of health informatics and mHealth, and who together truly represent the global, regional, and local perspectives that include national and global policies and priorities, successes and challenges, government and donor views, domains of public-private partnerships, and pilots and scaling up of E and mHealth programs. While we learn how E and mHealth are rapidly breeding and growing in Bangladesh, we, the Bangladeshis, will also learn where other countries are making differences. So, there is no reason why this conference will not be engaging, productive, and successful to benefit every participant of this conference.
In front of you today from the Department of Reproductive Health and Research in Geneva, Switzerland. When I started 20 years ago working in South Asia, I remember fondly to a time when we were in health facilities and we were working with providers and clients themselves as patients, and there were paper systems, and there were systems that there were 5-year waiting lists for telephones, and people were very much in a situation of not having access to information. Countries like Bangladesh have been able to utilize digital technology to realize the Millennium Development Goals, as well as begin to plan for the post-Millennium Development Goals and meet their own national goals.
Gentlemen, I would like to first wish you a very warm welcome, and thank you very much for taking the time to join us here today.
Experiences. But over the past 2 decades, we have seen a transformation occur in the global society. There are now, according to the ITU, the UN agency tasked with monitoring wireless technologies globally, the same number of mobile connections on this planet as there are human beings. 6.8 billion individuals own a mobile phone. The power that we all have in our pockets to reach out to another person, even though they may be miles and miles away, and connect to them within minutes, is something that is really transformative, even in the health sector. And then finally, creating opportunities. For me as a public health professional, to know when a birth has taken place in a village. We use mobile tools for supply chain marketing and moving the field forward. It's access to information to promote behavior change and help people monitor their behavior. For frontline health workers to be able to look at their phone and know the number, and from the health system level, here at the national or at the district levels across South Asia and much of the world, monitoring the workforce, knowing that community health workers are where they're supposed to be when they're change communication experts, health globally, that there has to be financial resources, there has to be functional facilities that are staffed with qualified individuals, transportation options have to be available, and data utilization, the backbone of health informatics, is taking data. Lastly, it's my pleasure to announce that we were just launching today a new article on mHealth in the Journal of American Medical Association. They embargoed this manuscript especially to be launched with today's conference. So it's a real pleasure to be able to highlight some of the work that's being done in the space of neonatal health using mobile tools in a prestigious place like the Journal of American Medical Association. It also means that people are taking this very seriously. We're no longer on the fringes of healthcare, but we are central to improving lives. And so I want you to please feel free to be inspired and learn from each other over the next 2 days to understand what is truly mPossible. Thank you very much.
Hi, good morning, everyone. Just to get to know my audience a little bit more, I'm just curious, how many people in the audience work directly within the healthcare? Maybe a show of hands. Okay. And how many of you think of yourselves as geeks? A few of you. Okay. Work within healthcare directly and those who work with information technology, and we're looking for ways in which we can apply technology to healthcare. And so it might not surprise you when I say that I believe that information is care. Information is very fundamental to the process of healthcare, and what I do in my practice is I basically work with information. Within the environment that I work within, and I make partnership with a school called Moy University that we put in place, and it's broken, and we need someone to go for an hour to get to a forum to build these medical record systems, and they struggle. And for us, we see the technology and getting someone to make this logo for development and ownership. I think it's also really important. Rima is a great example of someone who started. When you invest in the community,
as you can see, I'm not a healthy person, so I love to talk about health. And I'll talk about things which are quite different. So I think it's better that you test this last, because after that I understand you have a tea, so it just goes well. So that's my other way of saying sorry that I'm late. But anyway, so I'll be talking about digital Bangladesh. Digital Bangladesh is not a promise for a different world. It's actually a promise for the same world, much better, much quicker, and much more responsive and less costly. At the same time, it's a different world to different people. To a student, it's higher quality of education and being market ready. So, first principle that we adopted is we went bottom up instead of top down. Of the male by 17%, reduced all the complaint that on an average 20,000 families had against each of the sugarcane mills. So I have 0 minutes, I have finished it, thank you.
At the Pakistan's Federal Ombudsman Secretariat in Islamabad, and we are basically concerned the Federal Ombudsman of and used to exist in our systems, and because of those problems, we had to face a number of problems in the past. And as a matter of fact, in the year 2012, there was a measles outbreak in Pakistan, due to which about 150 innocent children lost their lives. And at that time, the Federal Ombudsman of Pakistan took notice from the experiments which have taken place in mHealth and electronic health, e-health programs in other countries, including Bangladesh and South Asian countries. And we would like that and are trying that we introduce and develop those systems during the course of time.
It's a pleasure and privilege to be here this morning with you. I've enjoyed the sessions, and so far I haven't fallen asleep from my jet lag, and I hope to continue throughout the day. As we are all aware, innovations and health agencies that contributed to this effort, listed on the table. And also in the World Bank, we also have a working group on CRES. This is a multi-sectorial issue, so you have people from different sectors who work together on this. The objective of the plan is to prepare a plan that, so in these countries, you will see that The coverage for immunization and antenatal care is very high. But if you look at standards, I wouldn't go through the whole list. We need to set the standards for the tools that we need to support countries in strengthening CRBS. We also need to help with implementation research. As we do our pilot programs, as we implement the programs, we need to know what worked well, what worked less well, and then what needs to be done, what will be the recommendations and lessons learned for other countries as well. Now that we develop the plan, what is the next step? The next step, as I indicated earlier, the objective is to do what? Is to mobilize resources for strengthening CRBS. So that is the stage at which we are now. What we are doing now is trying to talk to other donors and development partners with all of you in ensuring that we have 21st CRBS systems and national identity systems in the near future, not too distant future. Thank you very much.
Grateful to have the opportunity to speak with you today about the work of the mHealth Alliance and our role in helping drive the adoption of ICTs in Nigeria as part of the Saving 1 Million Lives initiative. And this, as you may know, the mHealth Alliance is now, this work has been subsumed into the broader United Nations Foundation work. And so there's probably a little bit of mixture between UN Foundation and the mHealth Alliance in this presentation, but you can assume it's working as basically the same organization. In cost and what does it look like to scale? I think it's not a linear pathway, it's iterative, it's cyclical. They have to continually readdress these questions and interacting different institutions and organizations and the political side of this. And so in this $5.5 million project through Health and Ministry of ICT through NORAD support, the beginning point of this is really setting up a partnership. And I do want to walk through these steps because I think it's really important to see one example of the how. What are the actual mechanisms of this neutral broker approach of engaging with the government? Of these reports, the timeliness of them was all very poor, to the point where in 2012 they were actually only 6 states were reporting more than 30% of reports on time. So out of 37,000 facilities, it was about 30% of reports were arriving. So, thank you.
So in the introduction, so the history of Bengali culture and the tradition is very ancient, but to be honest, the e-health in Bangladesh in public sector is relatively very recent. It began in 2009 with the Digital Bangladesh Vision 2021, and we have impressive progress since then in terms of e-health. We got the independence in 1971. You can see the National Museum in Shabar, very close to the Dhaka city. The visitors can have a look there. So after that, our father of the nation, Bangabandhu Sheikh Mujibur Rahman, he dreamt of a Sonar Bangla, that is the Golden Bengal. So Digital Bangladesh is nothing new, but the modern version of the dream of Golden Bengal. And you can see the cover page of the Digital Bangladesh. Actually, it was the election manifesto of the present ruling party in 2008, and it has taken the concept of Digital Bangladesh in Vision 2021. So, what is Digital Bangladesh? If I want to make it very brief, we can define it to make all the services easily available and affordable for the people by the use of computer technology. As simple as that. And what is digital health? Just put the word health in front of services. So it comes like that, to make the health services easily available and affordable for the people by the use of computer technology. And not only quick, but definitely qualitative. That is the better decisions will come out. Bridging urban-rural digital divide. Scaling e-health to community clinics and the community health workers. I hope you have already come to know about the community clinics. It is the very unique project that has been formulated by the present ruling party. Rather, it has been dreamt and implemented by the Honorable Prime Minister Sheikh Hasina. We have a plan to build 18,000 community clinics at the community level for the poor people to reach the health services at the doorsteps of them. So it has been already lauded by the international community. DPs, NGO and other providers have created a congenial environment towards scaling up e-health in Bangladesh. So thank you very much. So the hand on the right is the artificial one, but hand of us is very natural. So warm welcome to you, all the delegates. Thank you very much.
Thank you, Doctor, for the kind introduction. Good morning, everyone, and it's a pleasure to address this audience. We thank Professor Azad and the organizers for allowing us to give this presentation. So my outline is made up of basically two parts, something about AHIN so that we have the context on why we're doing this advocacy on governance and enterprise architecture. And the second part is basically focused on enterprise architecture. So very quickly about AHIN, because you can find most of the information from the brochure anyway, which you can get from me. It started as a series of events starting in 2011 in Hoi An, Vietnam, April 2011, where about 120 participants from 20 Information Systems Forum Country Ownership and Leadership Conference was now hosted primarily by WHO and supported by the other partners. And the countries here went through a workshop of using the Health Metrics Network framework to review their state of health information systems. And in the sharing sessions, in the plenaries, patterns emerged with the way they have, in terms of their health information system status.
We've had a lot of pilots as well, and our health minister told me, Dr. Herbosa, how come we have so many pilots and no airplanes flying? So that's basically the problem of mHealth and eHealth. You have so many pilots and there's no big airplane or 747 that flies off the ground. He said, Dr. Herbosa, in 2011, he told me, I want airplanes flying off the ground. So that's basically what we did. We initially thought it would be done with money, policy level. If you are able to present to me technology that will actually provide something that will allow me to change policy or direction, whether it be in a rural birthing center or in a modern hospital in that particular middle-income country. So we all come together here and we start to learn, and I'm very happy that Eloy actually pushed me to this. I was his professor in surgery before he delved into medical informatics, but we were been together all the time since then, and we built up the Philippine Medical Informatics Society. So I'm kind of a unique animal, nerd policymaker, you can call it, because I've been tweeting since this morning all the events to all my colleagues in Health XPH in the Philippines, and they're all very much interested in what's happening. So what we need is really to create that army. If you want a general to lead you, you have to have an army that will follow the orders and create that particular framework or strategy. Thank you very much and good morning.
Actually, I was requested Professor Azad, who is hosting this session, to invite me so that I can learn something from this session, since I saw that I am healthy here. Actually, I started my career in 1975. I created a nice family planning along with other groups, and then I moved to health. I worked there 5 years. Now I work with CIDA at the nursing sector as a NIS specialist. However, definitely the sessions, all the papers, all the experts, whatever spoke, it's a great things I think I learned from them. But I have only one simple question. With these rapid changes or growing field of health and health, how you are negotiating with the quality of the routine data device, because the e-health and health, so far I have seen many presenters presented related to his health information systems. In Bangladesh, we conduct a lot of national level surveys. It's cross-sectional surveys starting from 1975. I think more than 1 dozen of surveys. And the policymaker, the ministry people, the high-level people, mostly depend on the cross-sectional survey, that is the rates, ratio, whatever progress in relation with MDZ. But the routine data and or the mHealth or eHealth for a particular project area, particular locality, definitely generate information. how you are negotiating with this kind of data or comparing this kind of data with the routine data with the survey data. I do not see any comparative statistics. I was expecting that definitely, like the first presenter, the vital restoration, which country the first presenter, I brought it to the World Bank, right. In Bangladesh also there is a centralized vital restoration area. But you can do one thing, you can give or generate data through mHealth on the sample area and then compare these statistics with the other areas. So a lot of piloting areas are working, but I could not see.
He is correct. He is describing that whenever you have a pilot, you actually have a Hawthorne effect. Those of you who are in research understand that when you do a study that's made for an intervention, the result is always positive and it's always good. That's called the Hawthorne effect. And that's what you see. So that's why it's very important to actually have that enterprise architecture, because you will have what we call the big data. It's big data that's now going to be, like for example, trending. What is trending on Twitter? It is real-time data. If it's the World Cup of football, you will see what the trends are. And that's what we like to see as a policymaker. If you can give me a dashboard that tells me how many women are pregnant in my country at this particular time and who are about to deliver at this time, this is the type of stuff that policymakers will use. Now, we've gotten that data before in public health through surveys. And the surveys are, of course, estimates. They're inaccurate. And the value of what IT or mHealth does and eHealth does or digital health does is to make that data more accurate. That means I will make policies that are probably based on actual. And I will put funds, especially when there are meager funds in a middle-income country or low-income country, to the right programs that will actually have an effect. So the other thing is, the big data allows you to make the decision. The other thing, it will allow you to monitor and evaluate whether that program, the program doesn't change because of the eHealth strategy or the mHealth strategy. It's because you filled up a gap, let's say, in referral systems.
For example, we have got staff in the government system. So how can we know that the staff will actually not breach this security? So this is the trust and the confidence, and that actually the firm, under certain terms and conditions, are responsible for maintaining this. So whatever news we have got in the newspaper, actually this doesn't reflect the truth.
Our Chair, Mr. Saki Bali. So,
I'm based in Thailand. I'm from the Ministry of Health of Thailand, and we have a satellite secretariat office in Thailand too. So sometimes in the books they say that in Manila, Thailand. For me, I'm from Bangkok, Thailand, but it's all the Asian Pacific regions. For the first presentation, I would like to invite Dr. Kimberly Wallace to present the mHealth and mMoney experience from Pathfinder, Tanzania, Nigeria, and Kenya. Dr. Kimberly Wallace is the program director of the Pathfinder International, based at Massachusetts, United States of America. Please, Dr. Kimberly Wallace.
I have a greater appreciation for it, just trying to study up on the slides that she gave me today. I'm a program director for Pathfinder International and work with Asia Middle East programs. And I'm here on a visit to our NGO health service delivery project, the Smiling Sun project, that's funded by AIT and DFID. So thanks to the conference hosts for putting this together. It's really impressive to see the participation. It really shows a huge, I think, thirst for involvement in mHealth and interest in mHealth and technologies, and it's just really exciting to see. And I think, like I said, sort of studying up on these slides, I was unfamiliar with even the lexicon, so I think there's really an eagerness to get involved and to dive in, and I'm one of those folks as well. Pathfinder's been working in Tanzania for over 8 years with mHealth programs. It's and one of the longest running mHealth programs that really uses decision support applications. In Tanzania, we work in partnership with the Touch Foundation, and the program is funded by USAID, Vodafone, Swiss Re, and Elma. It's a 3-year program working in 2 districts with 111 health facilities and 250 community health workers. It basically links SMS, case sharing function via clinical decision support tools, GPS, tagging, and call centers, and integrates a number of different systems to work with pregnant women in emergencies and high-risk situations by USAID, Visa, and NetHope. And it's about a 1-year program that's just been extended. We work with community health workers and use a mobile application with community health workers, ComCare, to provide services for the MCH and ODCs, as I mentioned. So it's basically to set performance targets and work with the community health workers to incentivize them, to pay them, and motivate and track their performance. Essentially what happens is the community health workers will collect information on the number in Kenya, and so now where the budgets have gone local and a lot of the capacity building and the responsibility for health is now a newly a local level responsibility. That's really shifted and changed into how we would be able to integrate these programs into.
Afternoon, and thank you for the opportunity to allow me to speak to you today. I've been working in the Uganda space for about 5 years, but I also do provide a lot of support to UNICEF HQ and our regional office on our health system strengthening strategy as it relates to E&M health. So the request today was for me to speak on UNICEF's global, so we have automated events and slides. That's going to make it very challenging. I'm also going to present through the lens of a single country, Uganda, because I think it's much more interesting to effectively develop and manage a national information system. In this slide, it essentially is a disease that has been ravaging this space for a while. It's called pilotitis. This was the culmination of a mapping exercise that UNICEF supported in Uganda back in 2011. And at the time, we identified over 60 pilot programs that were, to all extents, successful. They were on. They were meeting every single donor metric, government, getting on the radio, raising issues like health worker absenteeism, and addressing what actions they're taking to address that.
About a slightly esoteric topic, but I hope it will, it's about the language of mHealth and bringing it to a level that we can all understand, both the health providers, decision makers, as well as the technologists, and finding a common language between the two.
So basically, I'll just sort of take on from Gareth left off. So M-Registry, which one of our colleagues basically kind of dubbed it as the Dropbox for global mHealth initiatives. So basically, so I'm going to just give you an overview of what it is about, why it has been conceived, and what value it is going to generate for a lot of the mHealth players, different stakeholders that we have. So that's the good thing. So that there's a lot of enthusiasm. People are doing things that people are trying to figure out what works and what does not. The bad are that a lot of the stakeholders, like the implementing agencies, like the government and the donors, they're basically trying to strive to figure out who is doing what in that space, what is working, what is not, and they don't have a good sense of that. The donors who are putting in money behind this, who are investing in these projects and initiatives, they're trying to figure out whether their funding is being most optimally used or not. And they don't really have a framework to figure that out either. And the regulators, the ministries of health, the WHOs of the world, they're also trying to figure out whether the initiatives are being duplicative, whether the standards are being followed or not. So they don't really have a sense of evaluating projects from that perspective either. So these are the bads. And the ugly, when the bad becomes ugly, is this, what you've already been exposed to, is what happened in Uganda. So when the bad becomes really ugly, this is the kind of letter that you end up with. So the letter basically says, I'll just read a small extract from the letter, which many of you possibly have already seen. It's all in one single visualization. So that is a very powerful tool, so that you can basically compare across projects. They can know about similar technologies that are being used for similar work, and then get a better sense of what is working, what is not. They can get in touch with relevant people.
but I have actually attended the presentation given by Dr. Mridul Chaudhary. Actually, what I see, I don't know actually how the registration process will be administered. It may happen that if it is open, right? So many projects, maybe from commercial, same project can be registered once and once again.
Thank you very much, Professor Azad. There's a lookup into the database, and it looks into whether a certain number of data fields are replicated. And if that's the case, it will query the person to determine whether or not there's additional information.
Question is a very important one, a question of why or how will people be motivated to register themselves?
As presentation that you told us that only 10% of the donor funded programs were known to the government.
What was happening in Uganda was that the oversight, the coordination of e-health was not really centralized within any one unit at the ministry. They had a group called the Resource Center who was nominally mandated for this.
You've been discussing the frameworks, the country ownership, the government's effort to coordinate the various different activities or strategies that are being implemented at country level.
Presentation. You mentioned in talking kind of about the feedback loop that Amtrak was using, that you guys measured data utilization.
What is your thinking about taking this private organization? Because now we are facing a lot of problems with the private sectors to put their data, to make them accountable to put the data in the government system.
And WHO and ITU provide an e-health national policy framework development approach, and I know that Bangladesh and a number of other countries have been utilizing that to develop a strategy, and that in itself provides the kind of policy environment that is clear. It delineates the engagement that can take place and the privacy factors and other elements that around data, for example, and it's an area that I know my other colleagues in the room have a lot more experience on, but I think it's an area that I think that it's not different. But there is as you say, there's a significant amount of service delivery that takes place through the private sector, and there is in many countries there is leadership that enables enforcement of policies in the private and the public sector that would and there can be incentives provided as well to ensure that there's compliance. But again, I think this is something that very much should be driven and articulated by government, and it should be a transparent process of development of that strategy as well as the execution of it.
Platform versus the strategy. And mRegistry, I think, is actually intentioned to record projects. So an implementation of DHIS2, an implementation of OpenMRS, in developed countries, in most parts of the US and Europe, there's a lot of awareness and public awareness and civil society awareness about ownership of data, confidentiality of medical data, and permissions for your data to be shared with others. I think we have a ways to go in Bangladesh, in India, Nepal, South Asia, Sub-Saharan Africa, to empower citizens to be aware that the data actually belongs to them first and then to others. And
Next, Dr. Bunchai will present to Mr. Sean Blashke. And if you could please remain on the crest to Mr. Mridul Chaudhary. Dr. Bunchai.
Since morning we are here and we are learning a lot. I can see in front of me all the mHealth, mCare, mTrack elites. Patient to the hospital. It helps transportation. It helps calling the. And I would like to see mobile as a life-saving intervention. And I hope you all agree with me. When I joined in January 2013, I realized that, as you can see, that 330 they are static clinics and vital clinic, only 52 of them were AMOG clinics. So when we provide antenatal care, besides those 52 clinics, we do not know what is happening to the women who after ANC4 go back home. Our presentation is use of mobile phones in improving maternal and child health in BRAC, right? Honorable Chair and respected audience, Assalamu alaikum and very good afternoon. For the next 15 minutes, I'll be talking about BRAC's experience in case of maternal, newborn and child health, a community-based health intervention. The sequence I'm going to follow is that I'll give some background and logic behind our incorporation of mobile phone in our MNCH intervention, and then I'll tell about my project and the services we are offering, and then how technology has been used in our project, and finally I'll conclude with the lessons learned throughout this project over the period. Bangladesh is still struggling to reduce maternal mortality, and the last Bangladesh maternal mortality survey, which was published in 2011, that 2010 data was presented, and the maternal mortality was 194 per 100,000 live births. And estimated 7,300 mothers are dying every year due to pregnancy-related complications. IMNCS project, and the pink star is the IMNCS project, and the Manushi, that means urban one, is the blue stars. Several services. We have reproductive health care, which includes family planning and reproductive morbidities. Pregnancy-related care has been offered, which starts with pregnancy identification, antenatal care, safe delivery at community, and postnatal care. In many aspects, we are using mobile phone, and we are developing a schedule for the health workers. That means a dashboard for the health workers who can then see the